Welcome, and thank you for participating in this training. This program focuses on our mass casualty incident plan and your role within it. These are rare events, but when they occur, they require immediate, organized action. Success depends on preparation, clear roles, and strong coordination. We'll review command, scene management, communication, and key updates to our system. The goal is simple: ensure everyone knows how to step in and operate effectively when it matters most. Let's get started. Mass casualty incidents require a coordinated regional response. The Central Shenandoah Valley Fire and Rescue Regional MCI Plan exists to ensure that fire departments, EMS agencies, and hospitals operate as one unified system when these incidents occur. The plan is intentionally designed to be practical and straightforward so responders can apply it quickly in the field. During an MCI, conditions are chaotic and time is critical. Clear guidance helps crews make rapid, consistent decisions under pressure. The most important principle to remember is providing the greatest good for the greatest number of patients. In a mass casualty event, we have to shift from the typical one patient at a time mindset and instead focus our limited resources where they will save the most lives. That means avoiding time-intensive heroic efforts on a single patient and instead relying on structured triage to identify priorities. Patients should then be distributed across all appropriate hospitals in the region. This prevents overwhelming the closest facility and helps ensure the entire healthcare system can support the incident response. Incident command and incident management systems. When a mass casualty incident occurs, the scene can become chaotic very quickly. The Incident Command System, or ICS, provides the structure that allows responders to manage that chaos effectively. At every incident, there is one incident commander responsible for overall management. Depending on the size and complexity of the event, this may involve a unified command with other agencies, a joint command structure, or a single incident commander. Regardless of the model used, there is always one person responsible for directing the incident. There should also be only one command post. This is where the incident commander and key command staff coordinate operations. On larger incidents, the command post may be located away from the immediate scene to provide better oversight and communication. The ICS structure is designed to grow with the incident. In a smaller event, the medical group supervisor may report directly to the incident commander. In larger incidents, a medical branch may be established to oversee triage, treatment, and transportation operations. It's also important to remember that the first arriving unit initially assumes command and all associated responsibilities until those roles are assigned and delegated to other personnel. Finally, ICS helps maintain an effective span of control, ideally between 3 and 7 personnel per supervisor, and reduces unnecessary radio traffic by limiting tactical communications to key leaders managing the medical operations. Once the incident command system is established, there are several key steps that help ensure the incident is managed effectively. First, command must be clearly established. As additional officers arrive, command may be transferred to ensure the most appropriate person is leading the incident. Whenever command changes, that transfer must be clear to everyone operating on the scene. Next, the organization should only activate the elements that are actually needed. ICS is designed to scale up or down depending on the complexity of the incident. That means assigning positions like triage, treatment, or transportation only when those functions are required. Delegation is another critical step. The incident commander cannot manage every task alone, so responsibilities are assigned to unit leaders and supervisors who oversee specific operational areas. Facilities also need to be established to support operations. This may include the command post, treatment areas, staging areas, or transport zones depending on the incident. Finally, incident objectives must be established and communicated. Early in the event, these plans are often verbal, but as the incident progresses, they may transition into a written incident action plan, which helps guide coordinated operations across all responding agencies. When EMS arrives at a mass casualty incident, there are several core operational priorities that guide our response. First and foremost is safety and size up. Crews must quickly evaluate the scene for hazards, determine the scope of the incident, and request the resources needed early. It's always easier to scale back resources later than to wait too long to request them. Command should be established as soon as practical so the scene can be organized and managed effectively. In some incidents, especially those involving active threats, patient access may require specialized teams such as rescue task forces working in coordination with law enforcement. Once patients are accessible, Providers should focus on immediate, life-saving interventions, simple actions that can quickly save lives, such as airway positioning, bleeding control, or opening an airway. From there, the system moves into triage, treatment, and transportation. Patients must be prioritized and moved through the system efficiently. Finally, responders must consider hospital capacity and patient destinations. As the incident evolves, leaders should continually reassess both patient needs and available resources, releasing excess units when possible so they can support ongoing community coverage and hospital operations.
Incident commander and initial response priorities. When the first unit arrives at a mass casualty incident, they immediately assume incident command. There's no delay. Those first actions set the tone for everything that follows and are often the most important of the entire incident. Right away, focus on safety and size up. These don't happen separately. They occur together. Identify hazards, secure the scene as best as possible, and keep incoming units staged until it's safe. At the same time, determine what you're dealing with, the type of incident, the number of patients, the severity of injuries, and how to move resources in and out of the scene. Communicate that information early to the communications center and request exactly what you need. Be clear and specific so the right resources are sent. Make sure hospitals are notified through the Virginia Healthcare Status and Alerting System. As things begin to come together, start building structure. Set up the incident command system. Establish staging, secure access routes, and identify areas for triage, treatment, and transportation. Finally, initiate triage operations as soon as possible using the SALT system. This ensures patients are quickly assessed and prioritized, so care and transport go to those who need it most. As the incident progresses, the incident commander continues to drive the overall strategy and tactics. While input may come from others, the responsibility for setting direction stays with command. Priorities remain constant, no matter the incident. Life safety comes first, for both victims and responders. That includes accountability and overall welfare. Next is stabilizing the incident, followed by protecting property whenever possible. A key step is establishing a single command post and making sure everyone knows where it is. This becomes the central point for coordination and decision-making. The command structure should match the incident. Not every situation requires every role, but if positions aren't filled, the incident commander is responsible for those functions. As the operation expands, the operations section takes on a critical role, managing tactical activities, organizing resources, and carrying out the strategies needed to meet incident objectives. The medical branch operates under the operations section, managing all patient care functions. It oversees triage, treatment, and transportation. This structure ensures clear coordination, efficient resource use, and organized patient flow during a mass casualty incident.
Medical branch operations. As incidents grow in size and complexity, a single medical group may not be enough. Large geographic areas and high patient numbers often require multiple medical groups to operate effectively. To maintain organization and a manageable span of control, a medical branch is established. This adds another level to the structure without changing the overall responsibilities. The medical branch director oversees all medical group activities and reports directly to the operations section chief. This structure ensures coordination across the incident while keeping operations efficient and controlled. The medical group supervisor, or medical branch director on larger incidents, is responsible for managing the entire medical component of the scene. This role reports directly to the operations section chief and ensures patient care operations run effectively. They oversee triage, treatment, and transportation through assigned unit leaders, while also coordinating support roles like medical supply. Early on, they establish the medical group, assign personnel, and designate leaders to keep operations organized. This position also ensures treatment and morgue areas are set up appropriately, resources are requested, and communication is maintained across all sections. They work closely with support agencies and ensure scene access, security, and traffic flow are controlled. Ultimately, the medical group supervisor keeps everything connected, making sure the right people, resources, and information are in the right place to support patient care. The triage unit leader plays a critical role in giving patients the best chance of recovery. Their first responsibility is ensuring triage is completed safely and effectively. Consider the scene. If hazards exist, triage may be delayed until it is safe, and patients may need decontamination first. They establish the triage area, organize teams, and determine what resources are needed. Clear communication with the medical group supervisor ensures resources are available and patient movement flows smoothly to treatment areas. Using porter teams behind triage helps move priority patients efficiently while keeping everyone safe. In addition, the triage unit leader oversees morgue operations if required, coordinating with law enforcement and the medical examiner, and maintaining accurate documentation throughout the incident. The treatment unit leader oversees all activities within the treatment unit, making sure patients receive timely and appropriate care. Their first responsibility is establishing treatment areas and ensuring sufficient resources are available. Patients are reassessed, re-triaged, and treated based on their priority, with proper use of triage tags to track them. Clear communication and documentation are essential, including maintaining an accurate patient count and sharing updates regularly. The treatment unit leader also coordinates patient movement to the ambulance loading area and supervises all personnel, including managers for immediate, delayed, and minimal treatment areas, to ensure operations run smoothly and safely. The transportation unit leader is responsible for managing all patient movement off the scene. Their focus is simple but critical, getting the right patient at the right time to the right facility. This role works closely with the treatment unit leader to make coordinated decisions about when and where patients are transported. It's not done in isolation. There must be constant coordination with treatment, ambulance staging, and air transport resources. They direct patient movement to the ambulance loading area and ensure a structure is in place to keep things organized. At the same time, they're monitoring patient flow and staying ahead of resource needs to prevent bottlenecks. Finally, they manage transportation resources by letting units know whether they should return to the scene for additional patients or be released from the incident. This keeps operations efficient and ensures resources are used where they're needed most.
The Medical Communications Coordinator serves as the vital link between the scene and receiving hospitals. They establish communication with medical facilities or regional control centers and keep track of which facilities can accept patients. They coordinate where patients will be transported, ensuring efficient distribution based on the severity of injuries and available resources. Accurate documentation of all communications and patient destinations is essential to support both patient care and overall incident management. The ambulance coordinator, also known as the staging manager, is responsible for all ground transport resources. Their first task is to establish a safe staging area away from the immediate scene. They maintain an accurate account of all ambulances and ensure resources are ready as patient needs grow. By staying ahead of potential shortages, they can alert the transportation unit leader before gaps occur. This coordination is critical to keeping patient movement efficient and organized during a mass casualty incident. The Helicopter Air Ambulance Coordinator manages all air transport resources during a mass casualty incident. Their first responsibility is selecting a safe and properly sized helispot for landing and patient transfer. They maintain ongoing communication with all helicopter units and ensure ground ambulances have safe routes to reach the helispot. The coordinator also requests additional resources as needed and supervises their use. Accurate documentation of all activities is essential to support patient tracking and incident management. During a mass casualty incident, the transportation recorder and transportation loader play key roles in patient movement. The transportation recorder keeps a detailed log of which patients are sent to which facilities, ensuring accountability and tracking throughout the incident. The transportation loader makes sure the right patient is on the correct ambulance and provides crews with guidance on reaching the receiving hospital. Together, these roles ensure safe, organized, and efficient transport of patients from the scene to medical facilities. The liaison officer is the key connector between all agencies and organizations during a mass casualty incident. They ensure information flows smoothly among hospitals, emergency services, public health officials, law enforcement, and government representatives. By acting as a communication bridge, the liaison officer helps manage patient distribution, coordinate resources, maintain scene security, and address public health needs. Their work reduces confusion, keeps everyone informed, and improves the overall efficiency and effectiveness of the response effort.
Regional coordination and communications. The Regional Healthcare Coordinating Center, or RHCC, serves as the hub for coordinating hospitals and healthcare facilities within a region. It works with the Virginia Department of Health and the Virginia Hospital and Healthcare Association to ensure situational awareness and central coordination during public health or mass casualty events. The RHCC tracks and shares critical information, coordinates patient distribution and hospital diversion status, and requests additional resources from other regions, the state, or federal agencies as needed. When an incident occurs, the Emergency Communications Center or the incident commander activates the RHCC to alert hospitals and healthcare facilities. Hospitals provide updated information on how many patients they can receive in the triage categories: immediate, delayed, and minimal, and confirm their capacity for mutual aid or evacuation scenarios. Activation requests should include incident time, type, location, initial patient numbers, and a callback contact. VHASS and NVERS ensure the right facilities are notified quickly and that field personnel can manage medical communications efficiently. Through this system, the RHCC helps optimize patient care, streamline regional response, and maintain coordinated communication across all healthcare partners during a mass casualty incident. During a mass casualty incident, having immediate access to the correct contact numbers is critical for efficient coordination. For the northern region, the RHCC can be reached at 8889-877-422 to activate the MCI Plan and alert hospitals. The Virginia Emergency Operations Center is available 24/7 at 804-674-2400 or toll-free at 800-46-88892 for additional state-level resources and support. The Northern Virginia Emergency Response System, or NVERS, will notify acute care facilities and coordinate patient distribution, ensuring hospitals are informed of their patient capacity and mutual aid capabilities. Keep these numbers readily accessible to streamline communications and support rapid response. Effective radio communication is critical during a mass casualty incident. All messages should be in plain English, no codes to avoid confusion. Only essential information should be transmitted, keeping channels clear for urgent updates. As the incident grows, channels can become overloaded. The incident commander may assign tactical and support resources to specific channels to maintain organization and clarity. Common channels include the command channel for overall coordination, the operations channel for on-scene tactical activity, the staging channel for resource management, and the helicopter air ambulance channel for all air transport communications. Proper use of these channels ensures responders receive the right information at the right time, which is essential for maintaining safety and operational efficiency during the incident. In Virginia, licensed EMS agencies are required to use either electronic or printed systems to track patients during mass casualty incidents, evacuations, or large-scale events. Redundancy is critical. Your system must have a backup in case of failure. The recommended system should capture essential patient information, including demographic details, triage category, vital signs, treatments provided, and a body diagram to document injuries. Barcodes or QR codes allow integration with hospital records and ensure accurate patient identification. Tracking patients on scene is just as important as recording their transport information. For paper-based systems, a tear-off section or a designated scene tracking section helps maintain situational awareness. Agencies should ensure their system supports seamless patient transfer to hospitals while maintaining accurate, real-time documentation. Our region uses the approved triage tag from Columbia Business Forms, LLC, which has been updated to include a gray or expectant triage category for use with the SALT triage system, as well as revised items in the treatment section on the back of the tag. This slide highlights the Augusta County Mass Casualty Incident Activation Guide. This is a key resource that supports both field personnel and the Emergency Communication Center during an incident. You can find the guide in several locations: the appendix of the Regional Policy Plan, the ACFR intranet, on the desktops of mobile computers, and as printed copies in MCI kits. It's designed to be easily accessible no matter where you are operating. The guide outlines the actions the Emergency Communication Center will take based on the declared level of the incident. That means once an incident is identified at a certain level, there are predefined steps already in place to support the response. On this slide, you're seeing the Level 2 guide as an example of how those actions are organized. While you're not expected to memorize every detail, all personnel should have a general awareness of the guide and, more importantly, know how to quickly access and reference it during an actual event.
Transition to SALT triage. Moving beyond START for improved patient prioritization. Our region is transitioning from the START triage method to the SALT triage system, and this change brings several important improvements. First, SALT allows for life-saving interventions during the triage process. Instead of only sorting patients, you can take immediate actions, like controlling bleeding or opening an airway, that can make a critical difference. Second, SALT uses a global sorting approach. This means you quickly prioritize patients based on their ability to follow commands or move, which helps establish order faster in chaotic scenes. Another key improvement is the addition of an expectant category. This helps guide difficult decisions when resources are limited, ensuring they are used where they can have the greatest impact. SALT also offers more flexibility in decision-making, allowing providers to use clinical judgment rather than following a rigid sequence. Overall, it aligns with current best practices and supports a more effective patient-centered approach to mass casualty triage. Let's refresh on the steps of SALT triage. SALT begins with a global sorting of patients, prioritizing them for individual assessment. Patients who can walk should be asked to walk to a designated area and should be assigned last priority for individual assessment. Those who remain should be asked to wave or be observed for purposeful movement. Those who do not move and those with obvious life-threatening conditions should be assessed first because they are the most likely to need life-saving interventions. The individual assessment should begin with limited rapid life-saving interventions. Control major hemorrhage through the use of tourniquets or direct pressure provided by other patients or other devices. Open the airway through positioning or basic airway adjuncts. No advanced airway devices should be used. If the patient is a child, consider giving 2 rescue breaths. Chest decompression, although we will not be providing decompression needles in our triage kits. Autoinjector antidotes if available. For example, if a chem pack has been deployed to the site prior to accessing the patients, antidotes may be available. Life-saving interventions should be performed only within the responder's scope of practice and only if the equipment is immediately available. After performing life-saving interventions, patients should be prioritized for treatment and/or transport by assigning them to one of 5 categories: immediate, expectant, delayed, minimal, or dead. Patients who have mild injuries that are self-limited if not treated and can tolerate a delay in care without increasing their risk of mortality should be triaged as minimal and should be designated with the color green. Patients who are not breathing even after life-saving interventions are attempted should be triaged as dead and should be designated with the color black. Patients who do not obey commands or do not have a peripheral pulse or are in respiratory distress or have uncontrolled major hemorrhage should be triaged as immediate and should be designated with the color red. Providers should consider whether these patients have injuries that are likely to be incompatible with life given the currently available resources. If the injuries meet this qualification, then the provider should triage these patients as expectant and they should be designated with the color gray. The remaining patients should be triaged as delayed and should be designated with the color yellow. This prioritization process is dynamic and may be altered by changing patient conditions, resources, and scene safety. After immediate patients have been cared for, patients designated as expectant, delayed, or minimal should be reassessed as soon as possible, with the expectation that some patients will have improved and others will have decompensated. In general, treatment and/or transport should be provided for immediate patients first, then delayed, then minimal. Expectant patients should be provided with treatment and/or transport when resources permit. Efficient use of transport assets may include mixing categories of patients and using alternate forms of transport. Some patients may only require treatment at the scene and not transport. As we wrap up, it's important to focus on what truly drives success during a mass casualty incident. It starts with that first unit, establishing command early and setting the tone for the entire response. Everything builds from a strong foundation of safety and size up. Understanding the scene, identifying hazards, and quickly assessing the scope allows you to make informed decisions from the start. From there, organization is key. A clear structure, defined roles, and coordinated efforts across all functions help turn a chaotic situation into a manageable operation. Triage plays a critical role in this process. By prioritizing patients effectively, we ensure that limited resources are used where they can have the greatest impact. Finally, none of this works without strong communication and preparation. Knowing the plan, Understanding your role and being ready to act are what make the difference when it matters most.